Good afternoon. Welcome to the Assembly Committee on Health and Human Services. Would the Secretary please take the roll?
Woman Gonzalez.
Here.
Assemblywoman Gorlow.
Here.
Assemblyman Gray.
Here.
Assemblyman Hafen.
Here.
Assemblyman Hibbets.
Here.
Assemblyman Koenig.
Here.
Assemblywoman Newby.
Here.
Assemblyman Wynn. Assemblyman Orentlicker.
Here.
Assemblywoman Taylor.
Present.
Assemblywoman Thomas.
Here.
Chair Peters.
And I am here. I believe Assemblyman Ornlicker is on the Zoom, and Assemblyman Nguyen will be here in a little bit. If you can mark him present when he arrives. Just a quick notice on the agenda before we get into housekeeping items. We have removed Assembly Bill 237 from the agenda for today. First of all, I want to thank the committee for being so gracious to each other and to our presenters throughout most of our committee meetings. But I do want to just remind folks that our standard in this building, in this room in particular, is to have grace and kindness for each other. And that if we have issues with particular policy, that we can vet that out in this room, but personal attacks won't be tolerated. So moving forward, I would just want to reiterate that we will not be tolerating personal attacks from committee members or from those who are testifying. General housekeeping items, please mute your phone and your computer so we're not interrupting speakers. We will have public testimony at the end of this meeting, but public testimony can be provided in a variety of ways on bills and for public comment. Those are all listed on the agenda. You may also submit public comment in writing either in addition to testifying or in lieu thereof. Written public comment may be submitted before, during, or up to 24 hours after the meeting's adjournment. If you wish to testify in person, please sign in at the table by the door and leave a business card so we get an accurate record of your name. If you do not wish to testify, you may still want to sign in so we have a record of those who are interested in these topic areas in case we are interested in reaching out to you. To ensure an orderly flow of discussion, all comments, questions, and responses must go through me. Also, committee members must be recognized by me before you can speak. Additionally, I ask our presenters on Zoom video call to leave your cameras off and microphones muted until it is your turn to present or if I direct any questions to you. When testifying in person, please turn the microphones on to speak and off to listen because we have others listening and we get some reverb if we don't do that. We will go ahead and move on with our agenda. As I said, we will have public comment at the end of the meeting today, so we will go ahead and start with our hearings. We are going to start with, out of order, we'll start with Assembly Bill 197. I'm going to let Assemblyman Orentlicker work his way onto the Zoom. Hello, Vice Chair. Thank you for being here today.
Good afternoon. Thanks for accommodating my need to be virtual. I'm going to try to share my screen. Okay, is it sharing well?
We can see it. Thank you.
Great. Well, thank you for the opportunity to present Assembly Bill 197, Chair and Committee. The idea here is to allow physicians, nurses, and other healthcare providers to request a tax to raise their Medicaid reimbursement. So why would they do that? Well, because Medicaid reimbursement rates in Nevada have been too low for too long. If we want doctors and nurses and other providers to take care of Medicaid patients, but we don't reimburse them well, and that can make it harder for patients to find a doctor. So it's unfair to patients when we underpay the providers, discourages providers from treating them. And we know that when we see surveys, doctors are less willing to see Medicaid patients than patients with private pay insurance. I remember when I was living in Indiana, a dermatologist colleague told me that a Medicaid patient had to come nearly 2 hours away because she was the closest dermatologist who would take Medicaid. It's unfair to providers too. When we undercompensate them, that's not right. They deserve to be paid a fair reimbursement rate. So the goal of this bill is to ensure that providers are fairly paid for taking care of Medicaid patients. So how does it, I said it's a provider tax, and so how does this work? So Medicaid allows states to impose a tax on different healthcare providers to raise money, and then you can use that to reimburse them. So if a provider group, and the way the bill is structured, this is voluntary. If the provider group requests a provider tax that we could apply to their net revenues, and different provider groups, there's about 18 listed in the federal statute, and this is the federal statute is in Section 5, but it could be physicians, it could be nurses, psychologists, therapists, occupational therapists, physical therapists, respiratory therapists, dentists, chiropractors, ambulance services. As I said, there are about 18 listed. We already have, since around 2000, we've had a provider tax for nursing homes. Hospitals have had authority since 2017, along with other facilities, and they've been working with HHS for a hospital provider tax. And here's what's so great about them. When you take these tax dollars and you spend it in the Medicaid program, and as I indicate, AB 197 would require the funds raised to be used to raise Medicaid reimbursement, then you get the federal match. So that roughly triples the dollars. And you return all of the funds to the provider group in the form of increased Medicaid reimbursement. So for every dollar they put in, they get $3 back in the form of higher payments for taking care of Medicaid patients. And it's an opt-in format. For the nursing homes in around 2000, the statute mandated the tax, but in 2017, the statute and this proposal allows for an opt-in. So if 67% of the providers in the class, whether it's physicians or nurses or psychologists, if they agree for the provider fee or tax, then this is in Section 6, it will go into effect. And then it can be used, as I say, to increase Medicaid reimbursements. And there's guardrails. These are in Section 7 to make sure that this works as intended, so that any dollars raised can only be used to increase Medicaid reimbursement. Can't divert it for other purposes. And the dollars need to be used to supplement rather than replace Medicaid dollars from the general funds. It wouldn't work if we just reduced how much we spend on Medicaid from the general fund. These have to be supplementary dollars, and as I say, to raise reimbursement rates. If funds remain at the end of the fiscal year, right, they're going to have to do a calculation. How much of a tax do we need to raise the money to increase reimbursement? They may overestimate or underestimate, but if there are extra dollars left for the next fiscal year, it won't go back to the general fund. It will just carry over to be used in the following year, again, to keep for these provider group to keep their reimbursement at Medicare levels. As I said, this is an opt-in. The providers have to vote for it. If there's any change in the allocation of funds, if there's some diversion of the funds away from raising their reimbursement levels, then they would automatically have to revote on whether they want to maintain the provider tax. So as I said, we want to make sure that if they opt into this tax, that we assure them that the dollars really will be used to raise their reimbursement and only for that purpose. Now, you might be wondering, what's the catch, right? This 3-to-1 match is approximate, but it's guaranteed. There's no doubt that if we use these dollars to spend to raise Medicaid reimbursement, we will get this generous federal match. The catch is that that's an average across all of the providers, whether it's hospitals or physicians or nurses. They'll get one on average, but the providers that see more Medicaid patients will do better than average, and those who see less, don't see as many Medicaid patients, will do less well than average. The nice thing is it creates a good incentive. The way you ensure that you get your money back and more is by seeing Medicaid patients, which is exactly what we want doctors to do. So, but that's been why this kind of a provider tax has not been implemented more broadly in Nevada and other states. You tend to see them more with long-term care facilities and hospitals, not so much beyond that, but I've been speaking with different provider groups. The ambulance providers of emergency ambulance services are very interested in this. Some of the others are thinking about it. And one of the things, I don't have an amendment today, but if there's a provider group that definitely does not want to have this option, then I will exclude them from the bill. Right now, this would cover any of the provider groups that aren't already covered in, I think it was Senate Bill 509 from 2017, but it's easy to carve out any provider groups who say, we don't want this option. So that's my have to say. I'm happy to take questions.
Thank you, Vice Chair, for the presentation. We do have several questions. I'm going to go ahead and start with Assemblywoman Thomas.
Thank you, Madam Chair, and thank you, Vice Chair, for the presentation. I'm just trying to understand the provider group makeup. So you'll have nurses, physicians, psychologists, but within the group, how many people form a group?
Oh. Thank you, Assemblywoman Thomas. Assemblyman David Ornlicker for the record. Good question. So each provider group is based on their professional classification. So physicians form a group, nurses form a different group, psychologists a different group, and it would be based on, for that group, if it's physicians, the physicians who are licensed to practice in Nevada. Or I guess one question, would it be just physicians who are in active practice in Nevada? That would be a question I'd have to ask the Medicaid program, but it would be based on physicians in Nevada or nurses in Nevada for the nursing group, chiropractors in Nevada for the chiropractor group.
Thank you. And would that include some of our unions that have nurses in their group? So would you include the union as a provider group?
Assemblyman Ornlicker for the record. All nurses would be, but I think they would be considered separately, not as part of the larger group. I don't think that, in terms of polling them to decide whether they want to participate, we would, as I understand it, the nurses themselves individually would be asked, would have the ability to vote.
Thank you, sir. Thank you, Madam Chair.
I have a question related to that, just for clarification on the provider group and determining the threshold, which I think is what we were just trying to get at. But I'm not seeing where we get the total number from, right? Is that all, like any provider of a certain service that's already certified through Medicaid? It's not just every provider in the entire state, those who take Medicaid and those who don't. Just clarify for us that group and population and what entity we grab that number from.
Thank you for the question, Assemblyman Ornlicker, for the record. Yes, what we have to do is we can't just apply this to the physicians or nurses or other group that takes care of Medicaid patients. You have to apply it. One of the requirements of the Medicaid program is that the provider taxes have to be broadly based. And so now how would we ascertain? So I think what we would do, I've done some talking with HHS here. Probably what we would do is the licensing boards for each of the provider groups would know who's in the state with that license. So we'd probably rely on the licensing board to tell us who's out there. But
Okay.
there's no question, it's more complicated when you're dealing with physicians or nurses than with hospitals. There's much more limited number of hospitals and easier to reach all of them. But
Thank you for that clarification. I have Assemblywoman Taylor next.
Thank you, Chair, and thank you, Vice Chair, for the presentation and really for this information. A couple of questions, if you will allow, Chair. One is for clarity. So just in terms of the tax, I want to make sure I'm just honed in on. So the providers, 67% of a particular group, provider group, as listed on your slide, would have to vote that yes, we want to pay a provider tax. And then each of them then would be, so we want to tax ourselves, basically, right? And they're saying that we'll tax, and the tax is based upon their net revenues. Is there who determines a percentage? Did I miss that? Is there a percentage? I may have missed that because I'm. No, that's 67% of the providers.
Good question.
Well, please go ahead. I'm sorry.
Yeah, thank you for the question. No, you didn't miss it, so thank you for asking, Assemblyman Orentlicker, for the record. So what we do know is under the Medicaid program, we would set the rate. The federal Health and Human Services limits it. It can't be higher than 6%. And we'd have to do a calculation. What's it going to cost? What would it cost to raise Medicaid reimbursement levels to Medicare levels? And then what would the level of tax needed to generate those funds? Mm-hmm. Would it be 1%, 2%, 3%? So that would be unknown until providers decided they were willing to do this, or they at least wanted to find out what's it mean for them. And then our HHS could do a rough calculation and say, here's what we project the tax to be. And then the providers could say, well, that sounds reasonable or not. And if they say yes, then that would be the rate that would be adopted. And then it could be adjusted over time if it turns out there was an underestimate or overestimate. Mm-hmm. But does that help?
It does. It helps a lot. Thank you very much. It isn't set yet. It can't be over 6%, but there's a process for figuring out what that might be, probably backing into the number. The second question, Chair, thank you very much for allowing it. As you mentioned, there were some things that maybe prohibited some other states, perhaps from jumping into this. Are there other states that currently that have a provider tax?
Thank you for the question, Assemblyman Orentlicker, for the record. I think every state, it's either 49 or 50 states, have a provider tax of some kind. But as I say, they tend to be more common with nursing homes like we do and hospitals. It's into taxes on individual providers like physicians or nurses are much less common and have been harder to do. And as I say, the problem is the physicians or nurses or other providers who don't take care of Medicaid patients resist these kinds of taxes. Mm-hmm. Now, there is a possibility, though it's complicated, to try to divide the class and say, okay, maybe pediatricians are eager to do this, while some of their colleagues are not. Can the pediatricians come in by themselves? And it's not easy to do, but because what the federal Medicaid program doesn't want us to do kind of cherry picking, pick out the doctors who see the most Medicaid patients and only tax them. They want the tax to be broadly based. But if the particular specialty, the number of Medicaid patients, the percentage of their patients that are Medicaid patients are similar to the state average, then you do have the option of bringing them in by themselves.
Okay, thank you. Thank you very much, Mr. Vice Chair. Thank you, Chair.
Thank you for the questions. We have another question from Assemblywoman Newby.
Thank you, Madam Chairwoman, and thank you, Vice Chair Orentlicker, for bringing this bill. I was recently really happy to hear that the hospital provider tax in Nevada seems to be on its way after many, many years, it seems. And before I ask my question, I just want to say it seems like we're in a sad state when we can't just fund Medicaid, and instead we need to collect taxes on providers to fund it themselves. So, but moving on from that, my question was about the administration of this tax and where you thought or who would collect that. You talked a little bit about the licensing board, so would they then or someone collect revenue figures from each of these participants and then figure out what the tax is and then send the bill? How do you see that in implementation?
Thank you for the question. This is Assemblyman Orentlicker for the record. The role of the licensing boards would be just to identify the members of the class. I don't anticipate them having any other role in this. That our Department of Health and Human Services would have the responsibility for deciding what the provider tax would be and polling the provider class to see if they want in, just as they're doing now with the hospitals.
Thank you, Madam Chairwoman. So who or what entity would you see being the implementer on the back end of the tax?
Thank you. This is Assemblyman Orentlicker for the record. Our Medicaid department or division at HHS.
We happen to have Stacy Weeks here today from Medicaid, who may be able to respond to this on how the implementation functions, or at least maybe the discussions that are occurring right now with how the hospitals are working through this issue and how they're able to do this kind of provider tax. Please go ahead.
Madam Chair, thank you. Stacy Weeks for the record, Nevada Medicaid. Yes, as the way the bill is written today, we would be the one implementing the tax and collecting the revenue and submitting for approval for federal and Medicaid share to make payments.
May I ask while you're up here about the administrative burden of that and how Medicaid covers those? I did not look at the fiscal note, but I was just curious of how I know this is a conversation that's happening with the hospital's provider tax. I don't know how it happened exactly with the nursing facilities, but if you could just tell us a little bit about how that implementation burden is covered under the provider tax model.
Madam Chair, Stacy Weeks for the record. So your first question has to do with the nursing facility has its own statute and it has its own requirements. They're different. They weren't polled necessarily like the hospitals. The administrative cost of this, we did assume, because the way the bill is drafted, similar to the hospital tax, that we would use a portion of the revenue to pay for our administrative cost. But I will say that when we looked up the number of providers, it was over 10,000 physicians that are licensed in Nevada, and so I think it is quite a feat and task ahead of us. Nothing is not doable, but I will say that we would have to definitely staff up and ramp up for this type of tax and payment structure.
Thank you. Assemblyman Koenig, I have you next.
Thank you, Chair. Is this tax, first for the record, I want to say that one of the irritants in my life is dealing with Medicaid, so, on the provider side, but is this tax going to be based on dollars billed or dollars reimbursed? Because those can be two fairly different things. Do you know what that tax is going to be based off of, what I should have got or what I actually got?
Assemblyman Orentlicker, for the record, good question, and I'll start, and if Ms. Weeks wants to fill in, great. It's important that the taxes have to be based on all of your patients, not just Medicaid patients. And I think it would be, there are different ways to do the tax. I know with facilities, it can be based on revenues or their number of beds. But I think for individual providers, I think it's based on net revenues is one option, but it would be all revenues from all patients, not just Medicaid patients, as I understand it. And as I say, if Ms. Weeks wants to supplement that, please do.
Thank you, Assemblyman. And Ms. Weeks, if you're available, thank you.
Stacy Weeks for the record. Yes, you're correct. We do use all claims and revenue, and we would be relying on providers to report that to us. So we would likely need to do some auditing because a lot of these, not every provider is enrolled in Medicaid. So it'd be hard for us to really validate the numbers that they're giving us. So we'd have to figure out a way to do some random auditing to understand the revenue that they're getting from other payers if we're taxing across all payers.
A quick follow-up, if I may. So then, is this available to all providers of Medicaid on the state, or are we only talking physicians? I mean, like dentists and optometrists and things like those that see, quite a few Medicaid patients. Does that tax apply to them, or is it only to physicians at this point?
Assemblyman Orentlicker, for the record, thank you for the question. So the bill would allow any of the different classes of professionals that you mentioned to choose to opt in. So physicians as a class would decide where do we want to be in. Optometrists and opticians, I think they may be combined, would decide as a class. Dentists as a class would decide. Chiropractors as a class, podiatrists as a class. They would all decide individually. So physicians could come in and dentists could stay out, or dentists could come in and physicians could stay out. Each group can decide for its own.
Thanks for that clarification.
I can also direct you to Section 5, subsection 1 defines provider groups under 42 CFR, section 433.56A1, which would include inpatient hospital services, outpatient hospital services, nursing facility services, intermediate care facility services, physician services, home health care services, outpatient prescription drugs, services of managed care organizations, ambulatory service, surgical center services, dental services, pediatric services, chiropractic services, optician services, psychological services, therapy services, which includes several variants of that, and nursing services, laboratory and x-ray services, and emergency ambulatory services. To give you an idea of the different provider groups that are out there. I have Assemblyman Hafen next.
Well, thank you, Madam Chair. And I'm going to follow up on my colleague, Dr. Koenig's question, because I don't think that it was actually answered, at least in the way that I would like addressed. And that is that, we're proposing a new tax. But we want to know exactly how this is going to be, how the tax is going to be implemented. Are we going to be billing or taxing the amount that is actually billed, or are we going to be taxing on the amount collected? Because those are two substantially different numbers, especially when we start looking at Medicaid. And I mean, we're talking about the difference between 100,000 and 20,000. So I really would like that to be addressed on how this tax is actually going to be implemented and what portion is going to be taxed. And Madam Chair, I do have a couple of other questions since I'm trying to do a follow-up on that one.
Thank you for the question, Assemblyman Orentlicker. For the record, my understanding is that it would be based on net revenues. So what do they actually collect less their operating expenses?
So on a cash basis or an accrual basis?
Wow, you've got some very complicated questions. I'll defer that to Ms. Weeks.
Miss Weeks, if you're available.
Stacy Weeks for the record. I'll have to follow up with you on how we're doing that with the hospital tax.
I would appreciate that. Thank you very much. And apologize, Madam Chair, I just wanted to get clarification on that question. So one of my other questions, obviously, I live in rural Nevada, and these taxes would be applied to our community as well. But as Doctor, our healthcare struggles. And so we barely get by, and we struggle to even get providers to come into our communities. And so I know that on the hospital side, there's been a conversation about a possible hold harmless. I just kind of curious if that is envisioned in this or not. I didn't see it in the actual language, but I was hoping that you could address that.
A good question. Thank you, Assemblyman Ortlicker, for the record. I would love to include something like that. Unfortunately, the federal Medicaid program disfavors hold harmless provisions. They don't like the idea of saying to the providers who aren't seeing Medicaid patients, well, at least make sure you get your tax dollars back. So while I like the idea of a hold harmless provision, that's not something that would work with the provider tax. So I say that hopefully because the return is so generous, 3-to-1 return, that will be enough to persuade at least some provider groups that this is worth doing. And again, the very nice incentive, especially for areas where you have lower income patients and not a lot of providers, knowing that they do well by taking care of patients on Medicaid. I think that's a very important incentive.
Thank you. And Madam Chair, this will be my last question, I promise. Well, I mean, I've got a bunch, but I'll take the rest of them offline. Dr. Ornlicker, you mentioned that there were some safeguards put into place in regards to the general fund. However, and I appreciate you doing that, because that is obviously one of the biggest concerns that I could see, looking at a recession, that these funds would be swept. And so what I understand from reading this is that this tax would be set in its own separate account and could not be swept. However, what I'm not seeing in here is a protection saying that, what happens when we don't have the general funds, and like we did during the special session, and we end up cutting Medicaid reimbursement rates, and now all that's really left is this tax. Now the providers are put in a position where their options are to raise their own taxes or go out of business, and so I just don't see those safeguards, and I'm hoping that maybe you could clarify that for us, and or possibly add that to your language. Thank you. And thank you, Madam Chair, for indulging me on the number of questions.
Thank you for the question, Assemblyman Ortlicker, for the record. I do want that kind of safeguard in, and I'd be happy to work on language with you, because you're right, we don't want this to be now used as an excuse to cut the usual Medicaid funding, or whatever safeguards would address that. Let's work on it and add it to the bill.
Thank you, Dr. Ornlicker. And thank you, Madam Chair. I do appreciate the time.
Interesting issue area. I have Assemblyman Gray next.
Thank you, Madam Chair. Quick question and a quick follow-up if the chair doesn't mind. It's a follow. The first question relates to Assemblywoman Taylor's question. You kind of danced around it, but are there any other states that have implemented this tax the way you see it on providers?
Assemblyman Orntlicker, for the record, good question. You mean, has anybody done it for individual providers like physicians, nurses, dentists?
I mean, the way you want to implement this, has any other state done this?
Well, I'll tell you, I'll try to answer. 50 states have provider taxes of some kind. We do, as I said, since 2000, for long-term care facilities, hospitals are negotiating. The 2017 bill did apply to personal care services, like home personal care services and other facilities. I'm not aware of any other group that's negotiating or shown interest. In other states, my guess is every state just about has one for long-term care facilities. Most states do for hospitals. In terms of doctors, I think Minnesota may still have a provider tax that goes beyond nursing homes and hospitals. I haven't looked at that recently to see if that's still in effect. So the ones for individual providers are much less common, but the ones for nursing homes and hospitals are widely used, and we're kind of a laggard overall in the extent to which we use provider taxes. So I hope that helps, and if not, I can do some research and give you more information.
Thank you. Madam Chair, quick follow-up. So if providers can opt in at 67%, can they opt out when they find out they don't, they're not getting the return that was promised?
Good question, Assemblyman Orntlicker, for the record. So let's say a provider group chooses and then decides this isn't such a good deal after all. There is in the bill an opportunity to re-vote if the rules change, if the money's diverted. So I haven't thought about what if the group just thinks it's a bad deal, can they re-vote? And so that's a good thing to think about, and I'd be happy to work with you and think about whether that makes sense. I don't know, and maybe Ms. Weeks does, whether other states have this opt-in. As I said, we didn't, for the long-term care facilities, it was just imposed. It wasn't an opt-in the way it is for hospitals. And I wasn't here when that design about saying rather than just implementing it, we'll give the providers a chance to vote on it. And I don't know if that kind of opt-in is common around the country. But again, Ms. Weeks may know more than I do.
Ms. Weeks, if you're available. Thank you.
Thank you, Madam Chair. Stacey Weeks for the record. No, I'm not aware of any other state that has this opt-in polling mechanism. Usually it's a mandate to tax providers, typically nationally.
I have one more question for you, if you don't mind staying for a second. It does pertain to Medicaid specifically. Assemblyman Hibbets.
Thank you, Madam Chair. Ms. Weeks, I'm just looking at the fiscal impact that you filed for this bill. And across the top, it says 0 for the biennium, but then when you get down into it, it's almost 10 million for the biennium. Can you just explain how we got to that point where it says 0, but now in the details it says 10 million?
Yeah, Madam Chair, Stacey Weeks for the record, Nevada Medicaid. Yes, so in the bill, there is a provision that says we can use, there's 3 purposes or uses for the revenue. The first 2 have to do with the payments to the providers. The third one is at administrative costs to the state. So while we show the cost, which is quite, as you can tell, to build up all the staff and the vendors that we would need to do this work, we're assuming that we would take a portion of that revenue to pay for it to keep the cost of the state neutral. That's how you get to 0.
Quick follow-up, if I may? So if you were to take a portion of that revenue, would that mean that the reimbursement rate would not go up as much as we would hope it would?
Madam Chair, Stacey Weeks for the record. Well, if you tax 10,000 physicians, it's a pretty big portion of funding. So it would go down a little bit, but I wouldn't assume it would be that big of a piece of the funds.
Thank you very much. Thank you, Chair.
I have a quick follow-up on that one, and I know we don't go into the fiscal in this committee, but I think that the implementation of this policy is important to talk about. So with that, that fiscal note and those dollars needed to administer the tax, would those dollars be able to be used to as the state match for Medicaid dollars? So those would still bring in that potentially 3-to-1 match.
Madam Chair, Stacy Weeks for the record. Yes, for administrative spend, we can claim federal share. It's actually usually higher than the 60% federal share, which is nice depending on what it's for, staffing or vendors or technology. I will say with this number of supplemental payments, collecting taxes, doing penalties for those that don't pay, all of those things will require a lot of effort, and today a lot of our work is manual. So I think if something like this was to pass and we were to poll providers and there was the 67% vote, we would likely need to look at software and technology to make our processes more automated and more reliable.
Thank you for that. Assemblywoman Newby. I believe this is our last question, so we'll move on to testimony after this.
Thank you, Madam Chair. Vice Chair Orentlicker, I've been struggling with the term tax in this bill because I don't know many taxes where you as a group decide that you're going to pay the tax and then potentially get back everything you paid in the tax plus 75% more. So what is the origin of calling this a tax? Is that required, or do other states call it something else?
Good question, Assemblyman Orentlicker, for the record. It might do well to use another term, but I'm not aware if that's certainly the commonly used term in the area. But if Ms. Weeks if there's other approaches, I'd be interested in knowing.
Ms. Weeks has approached the desk. Maybe she has some ideas.
Medicaid, Stacy Weeks for the record. Some people call it a fee assessment. Essentially the same thing. It's a tax. It functions like a tax, but I am not an expert on tax law, so maybe the Department of Taxation might have other ideas, but the way it's functioning is like a tax.
I could see it be something like the private supplemental Medicaid state fund or something. Interesting questions. All right, we're going to go ahead and move into support testimony. Thank you so much, Vice Chair. We will start in our physical locations in Carson and Las Vegas, and then move to our phones. Okay, in Carson City, do we have anybody here in support of Assembly Bill 197? Seeing none, I'm not seeing Las Vegas yet, so we'll see. Is there anyone in Las Vegas who would like to provide support testimony on Assembly Bill 197?
Yes, Madam Chairman, Brian McAnallen, McAnallen, for the record, representing GMR Global Medical Response, which is AMR and Medic West ambulance providers down here in Southern Nevada. We are supportive as an entity and kind of collectively as a ambulance association, as a provider class, supporting AB 197. We think that this is a great opportunity to do what we have been advocating for, and also have a bill that should be dropping today as a standalone provider tax for the ambulance class. This would affect us from the private ambulance side of the House here in accessing this provider assessment, whereas it was explained we would assess ourselves. That money would be put into a pot to draw down those federal dollars. So from a philosophic standpoint, this bill is pretty important because we're maximizing the state's opportunities to draw down federal dollars to support and supplement in this particular area where Medicaid reimbursement falls short. As you can imagine, our industry has been dramatically impacted by the last decade of rising costs and reimbursement rates which don't meet our needs. And with COVID, we've been hit pretty hard with the challenges of providing adequate revenue from our Medicaid patients. So this would help us significantly. I also want to point out that at least in our provider class, the public ambulance providers, so your fire departments, currently receive a similar program administered through state Medicaid called GEMT, which is Ground Emergency Medical Transport. And that was a bill that was sent through the 2017 legislative session. So it's a self-taxing or assessing on the private side to draw down those revenue, that additional Medicaid revenue. So for us, this is a parity bill that would allow the private ambulance providers the avenue or opportunity to participate in this program and draw down that federal match. I'll stop there and answer any questions that you may have.
Thank you. We do have a question. Assemblyman Hafen.
Thank you, and I just want to understand a little bit better on what you were referring to. If you could mute your mic. Thank you. When it comes to the ambulatory services, would, in your reading of this bill, would this now include Clark County or cities in this tax that would then go into the pool? Or would the private and the public stay completely separate under your understanding of the language?
Madam Chairman, Assemblyman Hafen, Brian McAnellen with GMR. As I understand it, this bill would provide for the class of service as ambulatory providers. However, in our state, I think the way it's written, it would allow for public and private. But in our state, we already have the public support getting the GEMT dollars that passed through the legislature that authorized the state to work on the SPA, the state plan amendment, to allow the private ambulance services to access those dollars on a reimbursement increase already. So they already have what my words, a look-alike program to what this looks like. So this, in our state, would enable or allow the private ambulance providers to kind of catch up and be on par or parity with a system that already functions for the private or for the public ambulance side of the house. Does that make sense?
Thank you. And I think we have an opportunity to vet out your bill coming up here in the future.
Thank you, Madam Chairman.
Thank you so much for your responses to the questions. Is there anyone else in Las Vegas for support testimony? Seeing none, BPS, I would ask that we check the public line for support testimony of Assembly Bill 197.
To testify in support of Assembly Bill 197, please press star 9 to take your place in the queue. Chair, there are no callers to testify at this time.
Thank you so much. We'll go ahead and move into opposition testimony. Is there anyone in Carson City who would like to provide opposition testimony to Assembly Bill 197? Seeing none. Oh, we have one coming up. I would ask in Las Vegas, if you're here for opposition testimony, please come up to the desk and I will call on you when we're done here in Carson City. Please remember to state your name for the record. You may begin.
Good afternoon, Madam Chair, members of the committee. My name is Sarah Watkins, and I represent the Nevada State Medical Association. The Nevada State Medical Association is opposed to this bill, as we do not support taxing physicians to pay for Medicaid, even with the understanding that payment rates might be higher. The promise of increased reimbursement is too unreliable, given the winners and losers of these types of taxes. The next time a budget hole needs to be filled, reimbursements will be cut, but the tax will remain. We understand and appreciate the Assemblyman for bringing to the forefront the conversation of increasing reimbursement rates. However, at this time, the Nevada State Medical Association believes it should continue to be a state investment in our healthcare system, specifically to the most vulnerable populations, and not carried by the provider themselves. Thank you for your time.
Thank you for your testimony. Please go ahead when you're ready.
Thank you, Madam Chair. For the record, Susan Fisher with McDonald Carano speaking on behalf of Nevada State Society of Anesthesiologists. And we do oppose the bill as well as written for the same reasons mentioned by NSMA. We opposed the bill when it was introduced last session as well for the same reasons. When we do hit a recession, that's one of the first things that gets peeled back is the Medicaid reimbursement rates. And anesthesiologists in Nevada are already reimbursed at a very, very low rate. So we would, if the bill does go through, we would appreciate the carve-out offered by the bill sponsor. Thank you.
Thank you for your testimony. Seeing no one else in Carson City approaching the desk, we'll go to Las Vegas. Please introduce yourself. For the record, you may begin.
Hi, I'm Susan Profit. I'm the Vice President of Nevada Republican Club. And I'm almost neutral on this until I just heard your Carson City opposition. You know, they have a good point. The tax always remains. And so I have to ask a question. Why a tax when we have $2 billion surplus here in Nevada? And thank you to Assemblyman Hafen. I really have a problem with not understanding the tax and the fact that they were not able to completely answer your questions to your satisfaction on how they would be applied. So I'm in opposition for that as well. But the main reason I think I just didn't see anything in here that said that the person receiving it would be having to sign an affidavit. Wouldn't that be a good idea to add to this as you are updating it? That's my question. Thank you very much. I appreciate your time and your service.
Thank you for your testimony. Seeing no one else in Las Vegas, I'd ask BPS to check the public line for opposition testimony to Assembly Bill 197.
To testify in opposition to Assembly Bill 197, please press star 9 to take your place in the queue.
Good afternoon. This is Connie McMillan, representing the Personal Care Association, and thank you for allowing me to speak, committee chairman and committee members. We are opposed to Senate Bill 197, or rather, we were opposed to Senate Bill 509 back in 2017, but it passed anyway and became law. The state Medicaid division did a survey, and the personal care industry resoundingly voted down the measure to tax ourselves. Not all PCAs accept Medicaid, and a lot of them are just mom and pops, and so we were not in favor of taxing ourselves. I'd like to say that I would like to thank the bill sponsor for bringing this and excluding us out of his presentation. And I had a very thoughtful conversation with him before today, and we did discuss this bill quite extensively. And so thank you for your time, and have a great day.
Thank you for your testimony. BPS, is there anyone else on the line for opposition testimony?
Chair, there are no other callers to testify at this time.
Thank you. We'll go ahead and move into neutral testimony. Is there anyone in Carson City or Las Vegas who would like to provide neutral testimony on Assembly Bill 197? Seeing no one approach the desks, BPS, is there anyone on the public line who would like to provide neutral testimony on AB 197?
To testify in neutral for Assembly Bill 197, please press star 9 to take your place in the queue. Caller, please press star 6 to unmute your phone.
Good afternoon, Madam Chair and Vice Chair. This is Paula Cook. I'm an occupational therapist in Las Vegas. Can you hear me?
We can hear you. Please go ahead.
Hi, I'm calling in today to testify in neutral. I applaud the effort to increase incentives to see Medicaid patients and to increase the reimbursement dollars. The current rates and the system are very frustrating for the providers in town, and I appreciate the opt-in option. However, revenue is often something that we don't see unless we're a private practice owner, so I think understanding that percentage of that revenue tax would need to be further clarified so that we understand how that's structured. And I'm going to take these details and share them with my colleagues so that I can survey our practitioners, as I'll need some more time to further understand the specifics. Thank you.
Thank you so much. And if you could provide the committee with your contact information, we can ask Vice Chair Orentlicker to reach out as well. Are there any other callers on the public line for neutral testimony?
Chair, there are no callers to testify at this time.
All right, we would invite Vice Chair Orentlicker for closing remarks if you'd like. Please go ahead.
Thank you, Chair. Thank you, members of the committee. As you've heard, there are some provider groups like the emergency services providers who really want this bill, others who really don't want to be involved, like physicians, and some who are like as the occupational therapists who are still thinking about it. And my intent would be to carve out the provider groups who aren't interested and preserve the option for those who would like this. And I'm happy to work with members of the committee on amendments to have more secure guardrails and make sure that the money is used only as intended. So I appreciate your consideration, and I look forward to continuing the dialogue.
Thank you so much for bringing this bill. We'll go ahead and close the hearing on Assembly Bill 197 and move into and open the hearing on Assembly Bill 293, which Vice Chair Orentlicker is presenting as well, I believe.
Thank you, Chair. David Orentlicker for the record, Assembly District 20. I appreciate the opportunity to present Assembly Bill 293 this afternoon. It's on the topic of medical legal partnerships. And thanks also to Richard Whitley and Stacy Weeks at the Department of Health and Human Services for suggesting this bill. And as you know, Ms. Weeks is here to help with any questions. Many patients have medical problems that can't be solved without addressing the social, economic, or environmental factors that contribute to the patient's illnesses. With legal assistance, healthcare providers can ensure that these social, economic, and environmental factors are addressed. For example, a child may be suffering from chronic asthma because of mold in the family's apartment. Legal assistance can ensure that the landlord corrects the problem. Another example, if a child or adult is being injured by domestic violence, legal assistance can secure a protective order or other interventions to prevent further abuse. Some patients may be unable to afford medications for their chronic diseases because their employer thought they couldn't work effectively and fired them. With legal assistance, we can ensure that the employer meets its obligation under the Americans with Disabilities Act to make accommodations in the workplace that allow the patients to resume working. Section 1.3 on page 2 of the bill describes other ways in which legal assistance can help patients, avoiding eviction or obtaining health care coverage, disability benefits, or other social services to which the patients are entitled. Maybe a patient is not getting enough food, their family's not eating enough, and legal assistance can get them the food stamp benefits that they need. In addition to providing legal assistance, staff at these medical legal partnerships can connect the patients with lawyers who can provide representation beyond the capacity of the partnership. In Reno, for example, Northern Nevada Hopes works with Northern Nevada Legal Aid in the medical legal partnership that we have in this state. And these partnerships tend to be based in hospitals or clinics, right, in healthcare settings where the patients are coming in to to get treatment, and then they can get assistance with their legal problems that affect their health. So where does AB 293 come in? Funding to support medical legal partnerships can be a challenge. There might be philanthropic funding. Maybe if you're partnering with a law school, the law school often helps, or the healthcare facility may have funds for this, but funding can be a challenge. And that's where AB 293 comes in. Section 1.1 of the bill, starting at the end of page 1, requires the Department of Health and Human Services to cover services provided by medical legal partnerships to the extent that money and federal financial participation are available. And to get those funds, to have Medicaid participate in funding, Section 1.2 of the bill authorizes HHS to apply for a Medicaid waiver to create funding for medical legal partnerships. North Carolina provides a good model for such a waiver. Other states with Medicaid funding for medical legal partnerships include Colorado, Indiana, Ohio, and Oregon. We've got, I think, decades now of experience with medical legal partnerships, and their impact has been demonstrated and very important in terms, as I said, of making sure that when there are social, economic, and environmental factors that are affecting patients' health, that those can be dealt with to make sure that the patient has the opportunity to have their health restored. So again, thank you for your participation. As I said, Ms. Weeks is here to help me answer any questions.
Thank you, Vice Chair, for the presentation. Do we have questions on Assembly Bill 293? Oh, Assemblywoman Taylor, please go ahead.
Thank you, Chair, and thank you again, Mr. Vice Chair, for bringing this forward. Just a quick question. You mentioned North Carolina. So is how common is this? Other states participate in such a program?
Thank you for your question, Assemblyman Orent-Licker. For the record, medical legal partnerships in general are throughout the country. In terms of where we have Medicaid waivers to provide funding, I've seen about 10 states listed, but that's based on an article that's a couple years old, so there may be more.
Thank you, sir. Thank you, Chair.
Thank you, Assemblyman Hibbets.
Thank you, Chair. Dr. Ornlicker, I have a question. I'd refer you to Section 1, subsection 1B, where it says, must be limited to providing advice and counsel to recipients of Medicaid concerning matters that have legal implication that influence the ability to secure or maintain optimal health. That seems a bit broad to me. What exactly are we looking at here? Are we talking about anything and everything that could possibly have any outcome on someone's health, or are we referring to something specific?
Assemblyman Orent-Licker, for the record, thank you for your question. And you're right, it does have some breadth to it. What we know is that these so-called social determinants of health, social, economic, and environmental factors do cover a lot of ground. That the food you can eat, where you live, the air you breathe. There are a lot of things. The water you drink, as we know from Flint and Jackson and other places. So what's important with the medical legal partnerships are designed to address is the fact that there's a wide range of factors can have a big impact on patients' health. And if we don't address those factors, then patients are going to keep coming back, and doctors are putting Band-Aids on and not really addressing adequately the causes of the patient's medical problems. So yes, there is some breadth to it, and that's just because the range of problems is pretty broad.
So based on that, you could use this law would address things such as rent or a gym membership. Is that correct?
Assemblyman Orntlicker, for the record, thank you for your question. So there would be some limits, and the Medicaid program would set those limits. That would be part of the waiver application, that they don't allow coverage of everything. One of the exclusions you notice is that they don't provide, the funds can't be used for legal representation. So it wouldn't, there are limits, and maybe Ms. Weeks, this is something if you're comfortable speaking to.
Thank you, Ms. Weeks.
Madam Chair, Stacy Weeks for the record, Nevada Medicaid. Yes, there would be limits, and I think some examples might be helpful. So for example, if someone's denied health care coverage, it would be helping that individual with that process. Sometimes it's seeking an appeal, letting them know where to find legal services. In addition to food stamps is another example. Some states look at also helping families that are dealing with child welfare issues, as well as like getting a restraining order for domestic violence, things like that that affect someone's health. And trying to make sure that they stay on track with their appointments as well. So it's working with that case management team together.
Thank you both, and thank you, Madam Chair.
Thank you for the questions. Thank you, Ms. Weeks. I have another question from Assemblyman Gray.
Thank you, Madam Chair. So, Mr. Orntlicker, we just heard you testify in the last bill, we need to increase basically reimbursement rates, so we need a new tax to do that, yet you want to turn around here and use Medicaid funds to pay for lawyers to provide services that in a lot of cases are already provided through legal aid, through social workers. I mean, this would create a swelling of a bureaucratic system, throwing lawyers into a mix where they shouldn't really be, I don't think. I mean, this is more of a paraprofessional world. I mean, how do you justify that?
I feel like we just heard that it wasn't going to cover legal services. Can you please clarify, Ms. Vice Chair Orntlicker?
Thank you for your question, Assemblyman Gray, Assemblyman Orntlicker, for the record. So yeah, in this case, the money would not be used for legal representation, but it would be used to provide legal advice and counsel. And in terms of the costs, what's important about these kinds of interventions is that they save money. Using the example of the child who's got chronic asthma because of mold, or there could be pests in the house that are causing the asthma. If that kid keeps coming back every month for medical care, that's going to be very expensive. But if you you remove the mold or the other causes of the asthma, you're saving a lot. Then the child doesn't have to keep coming back for treatment. So these are cost effective. Implementing medical legal partnerships saves Medicaid money. And so I'm not worried about the concern you raise.
Okay, Madam Chair, just a quick point of clarification. So wouldn't be used for representation, but counsel stuff. But the example you used was using, basically an attorney to help them apply for, for Medicaid. I mean, that seems to me like that's quite a few pay grades under the level of what an attorney should be doing.
Thank you for the question, Assemblyman Orntlicker, for the record. So there are variations in how medical legal partnerships work. Some, they do have attorneys who are based in the health clinic, and they can be kept busy providing advice and referring out. Again, the Medicaid funds would not be used for legal representation. If somebody came and their legal assistance was covered by Medicaid in Nevada, it would be to provide whatever advice and assistance. Sometimes you can point the patient to the forms and they can proceed on their own. And then sometimes they'll need to be referred out to legal aid organization, whether it's in Reno or Las Vegas or elsewhere. But they have worked very effectively. You don't need to worry whether medical legal partnerships can work, whether you can find the lawyers and other staff to provide the legal guidance and to make sure the patients get the services they need. They've been in practice, and we've had them for decades now, and they've been very successful.
I'm going to recommend we go offline with additional questions, but I do want a point of clarification on the legal assistance for applying for other services. We have a very effective partnership between our Medicaid division and DWIS division, the Division of Welfare and Social Services division, where they work relatively well together to ensure that folks are getting their needs met. So I'm hard to believe that that's going to be where we spend most of the time and effort in this legal medical partnership, but I do think it's important to note that many people who are on, I can almost definitively say that folks who are on Medicaid do not have a lawyer on retainer. And so this is an opportunity for folks to have access to legal advice rather than listening to friends or colleagues who may not be attorneys in navigating the medical world, whether it's through advocating within the medical industry or finding services, including paperwork that needs to be filled out to gain those kinds of services. And I think we can look at it from that lens rather than from an obligatory everybody gets a paid for lawyer lens. Are there any other questions from the committee before we move on? Thank you so much. We're going to go ahead into testimony then on Assembly Bill 293. We'll start here in Carson City and go to Las Vegas. If there are folks who would like to provide support testimony, please come up to the desks. Remember to state your name for the record. You may begin when you're ready.
Good afternoon, Chair, members of the committee. Jonathan Norman, NORMAN, Nevada Coalition of Legal Service Providers, which includes, I guess, all the attorneys that would probably take these types of cases. And to me, when I think of a medical legal partnership, I think of another door to legal services, right? So we operate in Clark County, the family law and the civil law self-help centers. Neither one of those organizations give legal advice, right? And here you actually have a situation where legal advice and counsel could be given, which is just, this is the path you go, and it's a step up from just providing a form. It's saying it's legal advice, right? And then if it required an attorney, legal representation, then they'd be able to make a referral to a legal aid provider is probably who they're going to make that referral to. So I view it as another door for people to enter to access legal advice, counsel, and potentially an attorney. It just highlights that attorney cannot be paid by this funding source. So. And in the past, at a previous legal aid I worked at, there was a medical legal partnership that functioned very well to provide another avenue for legal resources for, people who are usually in a pretty desperate situation. So thank you and support.
Thank you for your testimony. Is there anyone else in Carson City or Las Vegas who would like to provide support testimony? Seeing none, BPS, can you check the public line for support testimony on Assembly Bill 293?
Chair, there are no callers to testify at this time.
Thank you. We'll go ahead and move into opposition testimony. Is there anyone in Carson City or Las Vegas who would like to provide opposition testimony on Assembly Bill 293? Seeing none, BPS, could you check the public line for opposition testimony on Assembly Bill 293?
Chair, there are no callers to testify in opposition at this time.
Thank you so much. Is there anybody who would like to provide neutral testimony on Assembly Bill 293 in Carson City or Las Vegas? Seeing none, BPS, could you check the public line for neutral testimony on Assembly Bill 293?
Chair, there are no callers to testify neutral at this time.
Thank you so much. We are going to go, and thank you, Vice Chair Ornlicker. We appreciate you being here today. We're going to go ahead and close the hearing on Assembly Bill 293 and move on to our last bill of the day, our last hearing of the day, Assembly Bill 135. I'm going to invite our presenter down to the table, and we will give her a moment to get down there. Assemblywoman Gonzalez, thank you so much for being here today. I just want to remind the committee that this bill came out of the interim committee on Health and Human Services. Assemblywoman Gonzalez has graciously taken up the lead on this bill. Please remember to state your name for the record. You may begin.
Thank you so much, Madam Chair and members of the committee. My name is Cecilia Gonzalez, representing Assembly District 16 from beautiful Las Vegas, Nevada. Before we begin, I do want to note that there is an amendment proposed in Section 6. All of you should have that amendment on your desk. I'm not sure if it was posted on Nellis. No, not yet. It came in at the last hour, but it is a friendly amendment, and we do accept that amendment. This is a committee bill, as Chair stated, from the Joint Interim Standing Committee on Health and Human Services, in short, the HHS Interim Committee. At its final meeting and work session, the HHS Interim Committee voted unanimously to propose the bill before you today. With me is Trevor Macaluso, Chief Executive Officer of Eddie House, a nonprofit organization based here in northern Nevada in Reno, whose mission is to work with homeless and at-risk youth to help them develop the job and life skills necessary for sustainable independence. I will walk through the bill and then I will hand it off to Mr. Trevor for additional comments. Sections 1 and 2 require an issuing entity of birth certificates to notify applicants about missing paperwork for their applications to obtain an official copy of their birth certificate and also notify them of what kind of paperwork is missing. Additionally, if the applicant is homeless, they must be given at least 30 days to submit their missing documents. Section 1 also provides that a homeless person who obtains an official copy of their birth certificate from a government entity should submit a statement that they are homeless, signed under penalty of perjury, rather than a signed affidavit as currently set forth in the law. This issuing entity shall not require the signed statement be notarized. Section 3 aims to ensure that individuals experiencing homelessness are supported in their efforts to obtain a state identification card. For that purpose, DHHS's Nevada Housing Crisis Response System must collaborate with the Department of Motor Vehicles, otherwise known as the DMV, to facilitate that process. Sections 4, 5, and 6 apply to homeless children or young adults less than 25 years of age seeking to obtain an ID card with the intent to remove common barriers for this population. Specifically, Section 4 waives all fees and costs associated with the issuance of an ID card for homeless youth by removing the current limitations in law that the DMV can only waive these fees once. Section 5 removes the requirement to provide proof of a social security number to obtain a state ID card if the applicant submits a signed affidavit stating that they are a homeless youth. And Section 6 allows a homeless youth to provide their legal name and age by using their school ID card, as long as the ID card includes certain items listed in subsection 4, such as the school name, the applicant's first and last name, a photo of the applicant, and their date of birth. And you also have in front of you the amendment that was submitted that will also be able to use an unofficial transcript that includes the child or youth's date of birth. And lastly, Section 7 strives to strategically address the issues of homelessness in the urban areas of our state and mandate that counties with a population of 100,000 or more, meaning Clark and Washoe counties, develop a strategic plan to address homelessness within our county and cities and towns within that county. This section also addresses items that the strategic plan must include and require the plan be submitted and presented to the Joint Interim Standing Committee on Health and Human Services on or before August 1st of the interim, which would be 2024. With that, I'll hand it over to Mr. Trevor to conclude our presentation. Thank you.
Hi, good afternoon. Trevor Macaluso for the record, and I'm the CEO of Eddie House, Northern Nevada's only nonprofit accepting and serving any homeless or at-risk youth without any barriers in the area. We work with organizations across the state that work with youth homelessness, and this specific concept came about after being invited to speak, as the Assemblywoman stated, at the interim committee last April. We have an issue in being able to get identification cards for our youth. And why this is important is because we can't get them back to work or get them housed or on leases without ID. And the current system, basically we can get a birth certificate with relative ease, and then we're stuck in a loop between trying to get youth a Social Security card or Nevada ID because both require each other. And so this would help us to kind of close that loop on the Nevada ID side by using existing information that the state and the school district already has that could verify that a youth is who they say they are and provide that birth date, which would shorten a process of roughly 5 months to get a homeless youth an identification card to 2 months or less by our current estimate. And which is, again, the reason why we had this concept to begin with. And I'm happy to answer any questions about it.
Thank you so much for the presentation. We did something similar to folks who were incarcerated or came out of systems where they don't necessarily have identification to help assist in getting those very basics like needs met that you need an ID for, such as a Social Security card or others. I have a couple questions for you folks. I'm going to start with Assemblyman Gray.
Thank you, ma'am. Yeah, you may see me go sideways on this one. The government, if the government mandates you have an ID, which they do in just about everything. I mean, to get a COVID shot, you had to have an ID. So I think, if an ID is required for anything, it should be, it should be paid for. I've got a brother, that's chronically homeless, should have an ID. I mean, that's your gateway to living life. But, yeah, it's, and I think Assemblyman Hafen actually had a bill that pertained to something else that would have also provided an ID for people that couldn't afford it. So that's going to lead into my question. Why not just to people that sign an affidavit that attests that they can't afford it? They may have a roof over their head, but why does it have to be somebody that's homeless? Why are you guys limiting it to that?
Cecilia Gonzalez, District 16 for the record. Thank you so much for the question. I think that's part of a larger conversation when we talk about fines and fees and the DMVs and their budget. I don't know if anyone from the DMV is currently here to answer that, which is why we as legislators have to come and say, hey, what about this population? What about this population? Thank you.
And I guess that was my reason for the question, is why not just open it to people that attest that they cannot afford it?
Cecilia Gonzalez, District 16 for the record. Thank you so much. Again, that's a DMV question, and how they operate on their fines and fees from the little that I have had in conversations with them. And so I would defer that question to them.
I'm going to go ahead and take this question since it was from the interim committee. When we were talking about this particular issue, we were looking at ways that we could assist our homeless youth. It's one of the largest growing populations in the state of Nevada, and it also is one of the largest populations that we're seeing suicide in and other health issues in. So we really had a focus in on homeless youth, particularly this age range. But that is an opportunity. We could talk offline if you want about what it would look like to expand that, and we can work. I see that Mr. Seaver is here, but we could take this conversation offline with him to just ask about what that cost would look like for the DMV and move forward from there. Thank you so much for the comment and questions. I have Assemblyman Nguyen next.
Thank you, Madam Chair, and thank you, my colleague, to present this bill. This is more on the language barrier, because that's always been my line of questioning. In terms of past histories and affected population, have you interact or come across cases that there may be a language barrier added to the process of filling out this affidavit? And I just want to make sure that we're inclusive of those language barrier communities that may or may not be able to provide those statements in English. Thank you.
Thank you, Trevor Macaluso, for the record. Thank you for the question, Assemblyman. There is a language barrier across a number of youth that we might serve. As Eddie House, we work with strategic partners that offer interpretation and translation services as needed. And so we're able to address those quickly. I can't speak to other organizations.
Quick follow-up, Chair. And maybe this is a suggestion as we go along. I'm not sure if this is something that we could be amendable to adding that particular layer, because just in case where the affidavit is not accepted in any other language than English, then it may provide additional barrier, even though you may have services in your organization, but I'm just thinking statewide, we can look at how we can do this in an organization that may not have that capacity and be able to serve, the really, truly underserved population. Thank you, Chair.
Thank you. I actually am going to ask Mr. Sever if you could speak to or want to follow up with us on what languages the DMV does have documents in or translation services to. If you'd like to follow up, that'd be fine too, but we'll put it on our list for follow up. Thank you, Mr. Sever. Assemblyman Hibbets.
Thank you, Madam Chair. I actually have two questions, but they're both more procedural than anything. Of course, it relates to the policy that's in front of us today. Why get rid of the signed affidavit and go to a statement signed under penalty of perjury? What's the reasoning behind that? That's my first question.
Trevor Macaluso, for the record, thank you for the question, Assemblyman. One of those things is you need an ID to be notarized, and so it's really hard to actually have a notary sign the affidavit to verify that you're homeless. The only exemption that is provided under being a notary is like personally known individuals, and again, our population isn't necessarily personally known by the notary.
So if I understand correctly, an affidavit is something that is notarized. Is that correct?
Trevor Macaluso, for the record, all I can speak to is that the current process requires a signed affidavit verified by a notary, and it's very hard to have the notary actually notarize a document when the homeless individual does not have an identification.
Thank you. And my second question is on Section 1, Subsection 4, where we're talking about if they submit their application for an identification and they discover that there's documents that are missing. Is that going to be addressed right then and there, or are we looking, because my concern is, 2 days later somebody goes through these documents and goes, I don't want to use a name, but let's say John Q. Citizen is missing document X. Well, how are you going to notify him if they're homeless?
Trevor Macaluso, for the record, thank you for the question, Assemblyman. Usually the process is when a client or any homeless individual is trying to get their birth certificate and they have missing documents, the county would then contact that individual, whether that was by phone, email, or mail. The current situation, I believe, is that they have 21 days to pull together the existing documents, and this proposal would extend that to 30 days to give our clients a little bit of extra time. A lot of our youth at Eddie House have their mail delivered to us, and I know that's the case for other shelters as well.
My concern may not be best addressed by the NRS, but that was my concern, so I appreciate you answering the question. Thank you. Thank you, Madam Chair.
Thank you for the question. I have Assemblywoman Gorlow next.
Thank you very much, Chair. And I hope my question isn't too nitpicky, but I'm curious, and I know legal's not here. I didn't see a definition for homeless, so I just sort of wanted to put on the record exactly what we're looking at. I think, sometimes even in my quickness, I think of someone who's living on the streets, but then there's people who are couch surfing and people who may be in a hotel, an extended stay type of thing. So I just kind of wanted to get on the record the definition of homeless and all that it might encompass with this bill. Thank you.
This is Lily Gonzalez, District 16, for the record. Thank you so much for the question. On my page, I don't know if it's what it is on yours, but on page 8, I think it's section 6, subsection 5, number A. It defines homelessness, child, or youth as it currently is in the NRS.
Thank you. That was actually the definition I looked up last night, but I did overlook it in the bill language, so thank you.
No worries. Thank you.
Well, I don't believe that's a federal definition rather than the state definition. Are there any other questions from the committee members? Seeing none, thank you so much for the presentation. Assemblyman Gray.
Just a real quick one. So if they're homeless, and this is not meant to be sarcastic like that, if they're homeless, what are they going to use as an ID on their address? If they use the shelter, they frequently change shelters. What are they going to use? A last known family, residence?
Trevor Macaluso for the record. Thank you for your question, Assemblyman. Most of the clients use our address as a shelter, our shelter as the address or last known residence. Once we're able to get them housed somewhere, then we're able to change that and help them with that process. But again, they can't go to work, to find a job, to find a place to live without that.
And I have this vague recollection over the last couple of sessions that we've addressed that particular concern for broader homeless populations and identifications. Again, I don't know if the DMV has any ideas or maybe could follow up with how addresses for people who are homeless are dealt with at the DMV, but I do believe, if it wasn't for state IDs, it was for enrollment in schools. So we have some work already in that area we can fall back on and look at. Yeah, okay, we'll go ahead and move into support testimony. On Assembly Bill 135, we'll start here in Carson City and Las Vegas, and then we'll go to the phones. Is there anybody, I see people coming up here in Carson City. Is there anyone in Las Vegas who would like to come up to the table? I don't see anyone in Las Vegas. We'll go ahead and start here in Carson City. Please remember to state your name for the record. Go ahead.
Chair, members of the committee, Jonathan Norman, Norman, Nevada Coalition of Legal Service Providers. I was also a CAP attorney for a while, so I represented kids in foster care. And I had numerous kids who aged out, and through a variety of things, from being homeless, losing their ID because they were living in a park or couch surfing, this is like a real concern that I would face routinely for clients who had aged out, because we stay with them often until they're 21 as their CAP attorneys. And then I appreciated the question from Assemblywoman Gorlow, because I also had overlooked the definition, was assuming it was the federal definition, and I appreciated the question because there it was right in front of us. Thank you.
Thank you. Please proceed.
Thank you, Madam Chair. John Piro for the record, JOHN-PIRO from the Clark County Public Defender's Office. Sometimes it seems very little to us, but getting an ID is like a first barrier to getting yourself back into the game of life. And if we can provide an easier pathway, that's a pathway that keeps people out of trouble, that keeps people from repeating bad habits, that gets people back on the right path. So we're all for that.
Thank you. Please proceed.
Good afternoon, Patricia Haddad, Director of Government Relations for the Clark County School District. I'm grateful to the presenters and to the committee for bringing this legislation forward and for accepting the amendment in regards to the student IDs that are provided. Of course, we support this legislation and want to do what we can to ensure that our homeless youth and kids are supported. Thank you.
Thank you, and thank you for providing that language that will work for you all. It is complicated when we're talking about what to provide for our kiddos. Please go ahead when you're ready.
Good afternoon, Chair Peters and committee members. For the record, my name is Matilda Guerrero, and on behalf of Battleborn Progress, we are in support of Assembly Bill 135 as amended, as this is a common sense measure to ensure that every single Nevadan has access to the necessary documents that they need. We're elated to see that this bill requires the Nevada Housing Crisis Response System to collaborate with the DMV to help folks who are experiencing homelessness with their ID requests, while also waiving the fees for folks who are younger than 25. We urge this body to continue exploring creative measures such as this bill in order to provide folks with the opportunity to get back on their feet, seek out new jobs, housing, and assistance programs. Thank you.
Thank you for your testimony. Is there anyone else in our physical locations who'd like to provide support testimony on Assembly Bill 135? Seeing none, BPS, is there anyone on the public line who would like to provide support testimony on Assembly Bill 135?
Chair, there are no callers to testify in support at this time.
Thank you so much. Are there anybody who would like to provide opposition testimony to Assembly Bill 135 in our physical locations and then we'll go to the phone. For the record, I did not say this earlier, we do have kind of strict guidelines for opposition testimony, so I can appreciate that there may be some issue areas that have not been addressed yet. I would like to please state your name for the record. You may begin when you're ready.
Thank you, Chair Peters. Joanna Jacob, Clark County Government Affairs Manager, and thank you for the grace for explaining the committee rules, Chair Peters. Clark County is actually very supportive of this bill. Most of the sections of the bill, anything that can help reduce barriers for the youth that we serve in our Social Service Division and our Department of Family Services Division for our youth aging out of foster care, we always strive to help the kiddos that we serve. We have a long-standing program called Step Up where we help the youth transitioning out of foster care, understanding that that transition can be complicated and that they may exit and come back to us. We have a lot of support built into our system. We know that there are needs that are still out there. I am just opposed to the report and the mandate in Section 7, and I'll tell you why. Clark County and our community as a whole has actually begun in 2018 to do a strategic plan to address homelessness. This was a very significant effort with public and private partnership. And really was part of our Southern Nevada Continuum of Care, which is required by HUD and HUD-approved program that we recently updated in November 2022 with a needs assessment. My concern with that section was to be able to honor that work. And the work, very importantly, was youth-driven in collaboration with numerous community partners, the Nevada Partnership to End Youth Homelessness, and we had a youth advisory board who was really involved from the beginning to help drive and illustrate this plan and has participated throughout. So that's why we were very, 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 very lightly opposed on the new mandate for the report, just because we have already begun a strategic plan that has been updated. We'll be working with Assemblywoman Gonzalez on this afterwards, because we're happy always to report to the legislature on the progress that we have made and what we are working on in Clark County, but did not want to duplicate that effort because it has been really community-wide. Our continuum of care is very effective. It involves Clark County and the cities and numerous nonprofit partners. We just were awarded $15 million from HUD to address homelessness, one of 46 agencies awarded. And in Nevada, the Southern Nevada Continuum of Care was awarded that effort. That's over 3 years. So we're very proud of that effort and the community collaboration. That's why I'm opposed to the report. Very supportive of the rest of the bill and happy also to provide that report and needs assessment to the committee. If you would like to review, we can certainly upload that after the hearing today. Thank you.
Thank you so much. I think that would be appreciated by us, so we'll have staff follow up with you on those reports. Thank you so much. Are there other folks who would like to provide opposition testimony on Assembly Bill 135? Seeing none in the physical locations, BPS, is there anyone on the public line who would like to provide opposition testimony on Assembly Bill 135?
Chair, there are no callers to testify in opposition at this time.
Thank you so much. We'll go into neutral testimony. Is there anyone in Carson City or Las Vegas who would like to provide neutral testimony on Assembly Bill 135? We have someone here in Carson City. Please go ahead when you're ready.
Thank you, Chair and committee members. Sean Sever from the Nevada DMV. We are neutral on AB 135 and did submit a fiscal note with impact. The revenue loss is actually minimal to the DMV because this would affect a very small subset of our customers. Where the cost comes in is for the computer programming. The proposed effective dates are the issue. As you know, the DMV is in the middle of a transformation effort to move most of our services online. So we are between IT systems, and this would require programming, testing, and implementation in our old system at over 900 hours, which would need to be completed by contracted programmers. The DMV ask is to move the implementation date to when the DMV transformation is complete, which would significantly lessen the impact of it. Thank you, and if you want, Chair, I can address the questions that were asked earlier.
Yes, that would be great.
Sure. So Sean Sever from the DMV. To answer the first question, we'd have to assess the fiscal impact to add the other groups, and we'll have to get back to you on that one. The second question on languages, we accommodate is Spanish and Tagalog in Washoe and Clark County, and we're looking at adding Mandarin Chinese based on the last census data. And the third question for the homeless ID contact address. We do allow shelter addresses. And then once they get a permanent address, they come in to get their new card.
Thank you for those. Are there other questions for the DMV? Yes, Assemblyman Nguyen.
Thank you, Madam Chair. I was really interested the minute you said that you're going to add Chinese based on the census data. Does the census data also give you like top 5 languages in our state? And Spanish, Tagalog, and Chinese cover a good significant amount of population. When or where should we be looking at adding other languages? Because right now we're looking at, for example, my native language is Vietnamese, and that's another language that's commonly spoke, and the population has increased in this in our state. I just want to make sure where Vietnamese falls on that line.
Yes, Sean Sever from the DMV. We do have a language access plan that I can share with you offline, but I'll have to get back to you on some of your questions, please.
Thank you so much. Mr. Sever, do you have an anticipated implementation date for the new tech that you were referring to?
Sean Sever from the Nevada DMV. That's the $1 million question. So I would just say sometime in 2025.
Thank you so much. I know we've had exhaustive conversations about this in Ways and Means, but that doesn't always translate into policy committees, so thank you for that. Are there other questions for the DMV on this particular bill issue? Thank you so much for your testimony today. Are there other folks who would like to provide neutral testimony on Assembly Bill 135, either in Carson City or Las Vegas? Seeing none, BPS, is there anyone on the public line who would like to provide neutral testimony on Assembly Bill 135?
Chair, there are no callers to testify in neutral at this time.
Thank you so much. I'd like to invite the bill carrier for closing remarks if you would like.
Cecilia Gonzalez, District 16 for the record. I want to thank you and the committee for the time to hear this measure, and I will be working with Clark County to address their concerns in Section 7. Thank you so much.
Thank you so much for that. We'll go ahead and close the hearing on Assembly Bill 135 and move on to our last agenda item of public comment. We will start in our physical locations and move to the phone lines. We ask that public comment be kept to 2 minutes, and please avoid repetition of comments made by previous speakers. Staff will be timing each speaker during public comment to ensure everyone is given a fair opportunity to speak. Please clearly state and spell your name for the record, and then we will start your time. We will begin with public comment from our physical locations, Carson City or Las Vegas. Is there anyone who'd like to provide public comment today? Seeing none, BPS, is there anyone who would like to provide public comment on the phone lines today?
Chair, the public line is open and working, but there are no callers at this time.
Thank you so much. Go ahead and close out our public comment meeting item. Are there any additional comments from members before we adjourn? Thank you so much all for today. That concludes our meeting. We will meet again on Wednesday, the 22nd at 1:30 in the afternoon. With that, we are adjourned.